Well, welcome, everybody. It's wonderful to see you here. I just want to start with a few practicalities. I might give you my name first. I'm Anya Hurlbert. I'm representing the Public Lectures Committee, and I'm also Professor of Visual Neuroscience and Dean of Advancement here at Newcastle University. The first thing I want to ask you is to please keep your phones on silent throughout, and to tell you that we're not expecting a fire alarm, so if you hear one, it's real, and you should pay attention to the stewards who will tell you how to get to a safe place, which is out in the car park. And if you would like to tweet about tonight's lecture, please do so with hashtag InsightsNCL. And I just want to tell you that after the lecture, there's plenty of time for questions, so if you could hold them until then, that would be fab. I'm really, really honored to introduce Tom Shakespeare, Professor of Disability Research at the London School of Hygiene and Tropical Medicine and a Fellow of the British Academy. I'm really delighted, especially because we're welcoming Tom back to Newcastle University, where he co-founded the internationally renowned Center for Policy, Ethics, and Life Sciences back in 1999. For 25 years, PEALS, as it was called, performed world-class research focused on the social and ethical debates surrounding biomedical research. And he helped in doing that to establish the Center for Life as not only a world-class center for doing research in genetics, but a world-class center for understanding the ethical implications of that research, which relate to very deep questions underpinning our society and human life. And I think those are actually really topical, considering that tomorrow is the vote in Parliament on the assisted dying bill. And Tom has been very important in adding his voice to that question. But his core research areas on disability, politics, and culture, bioethics, and the ramifications of genetic research, and his advocacy for illuminating disability are by no means his only passions or his only routes to fame. He's worked in the arts, in comedy and theater and policy. He chaired the Northeast section of the Arts Council England. He worked for the WHO in Geneva for 5 years, co-authoring the World Report on Disability. He's taught medical students at Norwich Medical School, at UEA, and he now co-directs the International Center for Evidence on Disability at the London School of Hygiene and Tropical Medicine. He's written 10 books, including Disability, Rights and Wrongs, Disability, the Basics, and the Ha-Ha, and you've no doubt heard him on BBC Radio 4, or seen his television documentaries, or seen his stunning performance on ITV's 500 Questions. I think you missed 4 questions, something like that. Anyway, we're looking forward very much to your talk, When Healthcare Harms, Why Inclusive Treatment of Disabled People Can Avoid Health Inequities. Over to you, Tom.
Thank you very much. It's so, thank you. It's very good to be back here and to have all of you in my audience. I think I can call it my audience, so I think that's okay. I have done a few lectures before, and I used to lecture not here, but to the medical students up the road. And I'm quite a funny talker, and the Ha-Ha is not a serious book. I expect you to snort tea through your nose, because that's the best so far. If you can exceed that, if you die laughing, make sure somebody tells me, okay? But I used to do this lecture on disability way back, when I first moved to Newcastle in the Northeast in 1991. And I used to do a lecture to the medical students every year, and it was the same lecture, I'm afraid, but luckily they only heard it once. And they used to really enjoy it because it was quite funny, and they often used to clap at the end. It was really, you don't have to clap. It was really good because it's my pride and joy, it's my only lecture. And in 2002, I got married to an Australian lady called Caroline, and she was also disabled, and she also interacted with medical students. And she went along, she met these medical students, and she said, have you ever learnt anything about disability? And they went, no, never. And she said, you did, because last year don't you remember Tom Shakespeare came late? Oh, he was hilarious. He was great. What did he say? Can't remember, but he was very funny. He was disabled. I wasn't in a wheelchair, and I was standing, but I've always been short. And yes, they clapped, but they forgot. And that tells you two things. It tells you about the spiral of learning, and it tells you that actually, although I think that if you're laughing and clapping and enjoying yourself, you're learning, you may not be. You may actually be brain dead, but it's very funny. And that's good. Not that medical students are brain dead, far be it for me to say that. But the spiral of learning, how they learn about disability, that now we would say something like 15% of people are disabled. That's 1 billion and a bit people in the world. That's a lot of people in Britain. There's different scales and standards of how you can. So probably about 20 million of people. And of course, lots of people are aging and no longer able to do what they are used to. Some people are more disabled now or temporarily. Maybe they've been skiing. I used to fly from Newcastle. I don't fly anywhere now, but I used to fly from Newcastle to Geneva when I worked in Geneva for the early days when I was working there. And I used to go out and they used to have an ambilift. And I was the only person in the ambilift in Newcastle Airport. I knew them all very well. And they brought me out and they put me on the plane. And they're very, very good. And then coming back, I was not the only person. There was a lot of people. In fact, the place was positively crowded. And I hardly got a word in edgeways with my friends who helped me. Because they were all able-bodied going out. They'd been skiing, hadn't they? And you go skiing once a year, and it's very intense exercise, and you break your collarbone, or you pull your bit, or you terrible. They were walking wounded. They were coming back, which tells us something. Which tells us that we don't think of disability very much, but then it happens, and it happens because we do stupid things like skiing, or because we get older. Hopefully that's great. Living longer is fantastic, but there are many more disabled people. So I think it's really important to teach doctors about disability. So as I told you, I've done it in Newcastle, I've done it in Cambridge and Oxford and Leicester and Bristol and Norwich, as Anya kindly said, lots of places. And given that, not because disability is a health issue, but because 20% or up to, let's say 15% if we're going to go with the WHO, 15% of the population disabled, so they're going to see people who are disabled. And they might have a lot of patients who are disabled because they may have particular health needs and they may go more often, or rehabilitation needs and they may go more often. Or they may, for lots of different reasons, they may need. So it's really important. But as I told you, it's not the whole story. People hear a lecture, but they may forget it. And yet, disabled people are not disabled for 1 hour. They're disabled for their whole lives, maybe from their childhood or from the middle age or from their old age, depends. But for years and years, decades at least, I hope. And therefore, they will need their GP to know about them. They will need, and 50% of medical students at my place at UEA became GPs, and I imagine it's the same here. Lots of people become GPs, and they need to know because they're going to deal with disabled people and with older people, many of whom are disabled. Half of all disabled people are older, above 60. So there's an age gradient, very much so. So what I want to say was medical education is very important, but it's not the whole story. If you stop there, you haven't got the reason why disabled people are excluded. Not only because it's not just doctors for a start, it's physios and OTs and nurses and dentists and all the rest of it. People the porters, everybody. The secretaries have to know about disability, I think. So because they can get it wrong. I'll tell you a story. When I was at WHO, I did a lot of work on reproductive health, sexual reproductive health. And I've never forgotten a story that was told me by my colleague who'd done a huge amount of family planning and so forth. And it was from Mali. And there was a woman like me in a wheelchair, and she was very pregnant. She was going to have a baby. And she was in labour, early stages of labour. And she turns up to a hospital, and they laugh. They say, how do you become pregnant? That's funny, I've never seen the same person being pregnant before. Now, this lady is going to have a baby, which I believe is painful. And that is not what you should expect. And this wonderful person that I was around to for a number of years, Caroline, used to say, ask need to know, not want to know questions. So it's not their business how she got pregnant. That's her business, as it is with any woman, any person. What is there? What they need to know is, do you hurt in any place, and are you okay with this, and this transfer, or whatever, or this blue, or whatever it might be, or this drug, or whatever it might be. Those are need to know questions, not want to know questions. But I've never forgotten that story of that lady in Mali, because the problem is, and I'll tell you a bit more about this in a minute, the problem is that there are so many things that are got wrong. But first of all, let me tell you what they should be doing. So there are human rights standards. There's a Convention on the Rights of Persons with Disabilities, which was passed by the UN in 2006, which came into force in 2008, which is ratified by most countries in the world, something like 150 countries. So here's a trick question. This is the sort of thing you get on quizzes. How many countries are there in the world? You don't know, do you? It's 195. Well, maybe more now, because countries have a habit of splitting up. I say it's 195 because it was South Sudan, who were when I worked for WHO, who were the final people to join as a country, as it were. Something like 150 have ratified, more probably if you look at the website. And Article 25 is on health, and I can read through it, but you'll be very bored. But state parties recognise that persons with disabilities have the right to the enjoyment of the highest attainable standard of health without discrimination on the basis of disability. So states will take all possible measures and You can imagine what the sort of thing it says, rural areas. Health professionals are required to provide care of the same quality to persons with disabilities as to others, free informed consent, prohibit discrimination, prevent discriminatory denial of healthcare or health services. So there's a lot of words there which we all sign up to, all these countries sign up to. And it's a treaty. It's like tobacco control or the end of war or whatever it might be. You ratify it. It's a very formal, important process. And you are held to account. You go every 3 years to Geneva, where the Committee on the Rights of Persons with Disabilities says, now what have you done? And you have a report, and the country presents it, and there's a shadow report, which is presented by the rest of us, which is the real truth. And the country's a bit worried about what might be said, but it should be what people experience. And then people are held to account. And of course, UK was taken to court under that treaty and found to be discriminated against disabled people through particularly so-called welfare reform. Anyway, I'm not going to talk to you about welfare reform, but I'm going to present to you the evidence on failures under Article 25, the evidence about what we're not doing. I'm going to give you various sources of evidence, and I hope that some of them hit home. Maybe the story of the lady in Mali who's pregnant will hit home, like it hit home with me many years ago. Analysis of the 2006 US Medical Expenditure Survey disabled people were more likely than not disabled people to think a doctor had not listened to them, or treated them with respect, or taken enough time, or involved them in treatment decisions, listening to them, or explained treatments properly. So that's what they said when they asked in 2006. In the UK itself, the Disability Rights Commission in 2006 did a formal investigation into inequalities in health, and found that people with mental illness, survivors of mental health issues, and people with intellectual impairments, learning difficulties, received a worse service. So, me lecturing is nothing. People have been investigating this for decades. Now, when Anya was kind enough to mention the World Report on Disability, which we're very proud of, I'm very proud of, 2011, and had a chapter on health and a chapter on rehabilitation. And there had been a World Health Survey before that. So something like 60 countries, so that's something like more than a third of all countries have been involved. And thousands, I think 10,000 people were asked. And they asked people a whole set of questions. And they had a module, a set of questions to decide if people were disabled or not. Now this is important because disability is not a natural kind. It's not obvious. I could ask you to, well, I'm not going to ask you to stand up, you're disabled, but you would count the number of people in this room differently, depending on whether temporary impairment mattered, depending on whether neurodiversity mattered, and people were happy to say they were neurodivergent, or spectacles, are they okay or not? I don't know. I do know this, though, that I live very close to the National Gallery, and I went into the National Gallery one year, and I said, have you got any Bruegels? Like Peter Bruegel, the elder. And they said they had 3. So I went to see the Adoration of the Magi, and it's a nativity scene with the Christ child, all the rest of it. And I don't know that there's an earlier picture. This will be interesting to you, because obviously vision is your thing, but the earlier picture of somebody wearing spectacles. And there's a man on the right-hand side of the canvas wearing big spectacles. And he's looking the wrong way. He's looking away from the Christ child. And I think that Bruegel was painting it deliberately like that to show you that, as they say, as St. Paul said in Corinthians, there's none so blind that they cannot see, I think. And he doesn't see it at a deep level. He has got the spectacles, but he doesn't see what's going on, that this is the saviour of the world, according to Pete Bruegel and the people who commissioned the picture. So, the total deviation, I don't know why I'm talking about Bruegel. Anyway, back. So, we did the World Health Survey. Why was I talking about Bruegel? I don't know. Yes, because I was saying that we don't know how many people in this room are disabled. Maybe 15% if we're average, but maybe more, because I'm afraid you have grey hair, if you have hair, often. So maybe there's more, I don't know. But it's not obvious, is what I'm trying to say. We can't have an agreement, probably, between us how many people. But we can if we ask you questions. And if your answer to questions, you do a survey. We have a module on the survey, and the World Health Survey had a module of 8 questions. So you may not think that's enough, but 8 questions it was about physical functioning. It was about walking and being understood and all the rest of it. Anyway, on that basis, I'm just telling you, because there might be some social scientists or demographers in the audience, you'll ask the question, and you won't be able to answer it now. Ask it now. So they distinguish between people with disabilities and everybody else at that time who were answering questions. And that the World Health Survey found that people with disabilities compared to other people, the rest of the population, were twice as likely to find healthcare, equipment or skills inadequate for them. Were 3 times as likely to be denied care and 4 times as likely to be badly treated. See, I say tracked, that's a Geordie. Tracked badly. They were 4 times likely to be tracked badly. So this is one place I can say Tret without people going, don't you mean treated? And I no, I mean Tret. So they're 4 times more likely to be Tret badly. It really shocking. Twice as likely to find equipment or skills inadequate, 3 times likely to be denied care, 4 times likely to be Tret badly. And also, that same survey found that if you are disabled under that rubric, you are 50% more likely to have so-called catastrophic health expenditure. And what that means is, what the point about, I get very emotional talking about it. The point about catastrophic health expenditure is that it pushes you into poverty. You can't feed your family or live a proper life because you spent so much on healthcare. And often if you have a child or if you yourself have a disability or disease that can be treated, and you live in a low and middle income country, I'm afraid, or America, and you don't have health insurance, it's very, very expensive. We are so lucky to have the NHS, to have social health insurance in many countries. And if you have that, if you're pooled risk, if you like, disabled people are much better off. But 50% more likely. So that's one study. There's also a study called the SIPOLD study. And SIPOLD stands for, no, I don't even know what it stands for. That's terrible. But it was a study of the premature death of people with learning difficulty. So LD stands for learning difficulty. Disability is probably the title. And there was a report by MainCap in 2007 called Death by Indifference. So, and obviously you've just heard me talk about the Disability Rights Commission study, the formal investigation into inequalities in health. So the SIPOL study followed these deaths of people with intellectual disability in Britain, not in Mali or anywhere else, America or anywhere else, in Britain. And they investigated a sequence of events leading to all known deaths of people with disabilities, aged 4 and over a 2-year period. So there's a potential population of about 1.7 million. They reviewed the death of 247 people with learning difficulties over this 2-year period. So that was 2.5 times the number they expected to find. So in terms of the population, and 2% or 1% of the population, they expect to find fewer deaths. They found 2.5 times the number of deaths. And because we just don't see people, particularly people with mild learning difficulties. 2/5 of the people in the study who died had previously, the people with learning difficulties, had previously lived in long-stay institutions and were then in community. 96% were white. So the median, I don't know how long you think you're going to live. I hope you can live for a long time, but you will, you're going to live for a long time. The median age of death for these folk with learning difficulties was 65 years for men, 63 years for women. That's really bad. You hopefully will live well into your 70s, 80s, and there'll probably be a number of people who live to 100 in this audience. So men with learning difficulties died on average 13 years sooner than men in the general population. Women died 20 years sooner than women in the general population. So overall, 22% were under the age of 50 when they died. Now, of course, you could say, well, learning difficulties, they've got all sorts of problems. But 43% of the deaths were unexpected. So these were not, I don't think, they weren't expected deaths. They weren't connected with their condition, which could be a reason. They were unexpected. And they died of the same things, and the health professionals recognized the illnesses of 86% of cases. But there was delays in 29% of cases. So there's real delay or difficulty in diagnosing or referring or specialist investigation. And for 30% of those people, there are problems with their treatment. What they concluded was a lack of reasonable adjustments. So when I say reasonable adjustment, I don't know if you've seen that lift outside. It's wonderful. I've been up and down it, gone to the loo. Yeah, it's fantastic. But that's a reasonable adjustment. Sign language interpreters is a reasonable adjustment. More time is a reasonable adjustment, et cetera, et cetera. Those are what we call reasonable adjustments. And you need them. I need a loo I can turn around in. People need different things. And these folk with learning difficulties did not get those things in their healthcare encounters. People were not expecting, and it was not marked down. People didn't know that they needed, in many cases, these things. They didn't ask everybody whether they needed those things. Professionals were either not aware of or did not include in their usual practice these adaptations. A lot of the problems of the premature deaths were amenable to public health. That's the word they used. So what is amenable to public health? Well, housing, diet, transport, social care, all of those things. You can get them better. And if you get them better, these folk wouldn't die so young. And of course, they're still dying young. So that's a real problem. And just to give you an example, one of the things that lots of people with learning difficulties die of is aspirant pneumonia. And that's basically when food goes down the wrong way. Because, of course, we've got a very clever system with the esophagus and all the rest of it, where you can swallow and where you don't choke on food, generally, unless you're drunk. So you don't choke on food, hopefully. People with learning difficulties, if it goes down the wrong way, they can get pneumonia and they can die from that. And often people with learning difficulties are fed by people. And if they're fed by people in a hurry, can you imagine feeding somebody who needs to be fed? And you're probably not even paying any attention, you're talking to somebody else. You're not paid very much. You're paid really badly. So you're feeding and you're not looking, and you can see how the poor person can choke. And this repeated choking or the food going down the wrong way can cause pneumonia and death. So that's what we mean by, that's not because of doctors or nurses. It's amenable to public health. It's the way you're supported. And it comes down to the amount you pay the care workers, probably, and how much they value the job. And all that. It's a very complex, and how much training they have, and all the rest of it. So identify everybody. Many people had more than one condition. So if you are lucky to have a condition like, I don't know, muscular dystrophy or whatever, you're not necessarily going to have another. But multimorbidity is when you have lots. And what they found was that lots of people with learning disability had more than one. So they had lots of different things. They were not, the system was not prepared for it. And they needed, so these are recommendations: a named healthcare coordinator, patient held records, annual health checks. Now, I'm not quite 60, but I do have, I like my GP. I'm a nice white middle class person. Of course, we get on well. I am sent, I don't know, embarrassing to recount, but I'm at an age where I send a regular poo test screening kit. It's horrible. I tell you, being disabled, having used one of those things is much worse if you can't stand. Anyway, those sorts of things, screening, is really important, and making sure that you have them annually or however often. So the recommendations were that people with learning disabilities have access to the same investigation and treatments as anyone else. Remember what we signed up to in the Convention on the Rights of Persons with Disabilities. Barriers in healthcare to be addressed. And adults with learning disabilities to be considered a high-risk group for deaths from respiratory problems. Now, I don't know if you remember, but a few years ago we had a big problem with the respiratory problems and deaths, and people died a lot. And particularly people with a learning disability, people with disability generally, but particularly people with learning disability. died more than they should, depending on 4 times, 6 times, a lot more times more than they should. And of course, sometimes it's to do with the condition they have. So for example, I think it's right to say that people with Down syndrome are 30 times more likely to die from COVID. So that's to do with having a really not very good immune system. But the 4 times, or the 6 times, the 8 times, that's to do with not being tracked very well, not being paid very well, not being reviewed very well. And I remember a colleague of mine who does lots of videos for people with learning difficulties. Even you can imagine, I hope nobody was ill or lost somebody during COVID, but the facial mask with the CPAP, the positive airways mask, well, that's all right. You know what it is. You're not frightened of it. Well, that's not the case for lots of people with learning difficulties. They've never encountered it before, and they might be frightened of it. And that was why it's very important that they had that video about, and the booklet about that from Beyond Words. So it was not something I had to read, because most of you could read it, but they could not read it. Not all of them could read it. So things like that. And obviously we could talk about DNAR, proper guidelines, so they're discussed, and so forth. There's 18 recommendations. I won't go into them all. But there are 2 specific cases which I do want to talk about. And if you're in the NHS, you've probably had the Oliver McGowan training. So you know what I'm going to talk about now. Because in 2016, Oliver McGowan, who is a young man with epilepsy, you can find him online if you want to. He had epilepsy because of meningitis, I think. And he had some learning difficulties, mild learning difficulties. Yeah? So he was in hospital for complications for epilepsy. And he was given an antipsychotic medicine to which he was allergic. And he knew he was allergic. His parents knew he was allergic. It said in his notes that he was allergic. He should never, ever have been given this drug to which he was allergic. And I'm sure you're all allergic to something or other. And if you have it, you have a nasty rash or you cough a lot, or snot, or whatever. But he was allergic, and in his case, he was this drug was so powerful that he was so allergic, his brain swelled up and he died. Now, it clearly, listening to the patient, listening to the relatives of the patient, thinking about that before you said, no, I'm the doctor, I'm going to do what I want, don't tell me my job, or whatever. When the post-mortem, there was a suspicion of what's called neuroleptic malignant syndrome, which is a known serious side effect of antipsychotic medicines. So now all the clinicians in the NHS, and I'm sure if you are one such, you're a bit bored of it, but it is important. The Oliver McGowan Mandatory Training on Learning Disability and Autism, everybody has to know, because Oliver's mum campaigned, the family campaigned and campaigned and campaigned, and now all doctors, all nurses, all people working with people with learning difficulties have to have this training. And you can see that on the website, because I did. I'll quote what they said, why they have to have this training. Aiming to save lives by ensuring the health and social care workforce have the right skills and knowledge to provide safe, compassionate and informed care to autistic people and people with learning disability. Which is a long way of saying, listen to them. They kind of might know, and their families certainly know, and listen to them. And then you will avoid that. So there you are. I can't get a certificate. There's no CPD of this lecture. And that's, I think that was 2016. Yeah, 2016. Earlier than that, 2013, you probably heard of Connor Sparrowhawk. And if so, I'm sorry, I'm going to tell you again. So he was 18. He also had epilepsy. He was admitted to Slade House, which was run by Southern Health, which was a so-called assessment and treatment unit. So lots of people don't live in long-term institutions anymore. and lots of people are in so-called assessment treatment units, because that's how short term. But he was there for weeks and weeks and months and months. And it was only a 7-bed unit. It was quite small. So he was found drowned 4 months later on the 4th of July 2013. So I know, I hope you know, that if you're epileptic or you have a family member who's epileptic, you never ever leave them unaccompanied in the bath. And not only was he left on his own in the bath, the door was locked. So there was no way to keep in touch with what he was experiencing. And he was found unconscious in the bath because he drowned, and he died. So, really, I think, and there's Winterbourne View and lots of other examples. So there's lots of, somebody said on Blue Sky, which is the new Twitter, as it were, said, you haven't got any evidence. I said, I do. And you may think that my story about the Lady of Marley was bad, or you may say, oh no, the worst was the story of Connor Sparrowhawk, or the worst is the story of Oliver McGowan. It depends what you go for. If you go for Lancet Public Health, you've probably read Cooper et al. So Hannah Cooper, my colleague, who also found out that figure about the number of people with learning difficulties who are at danger of COVID. And you think that Anya and I, all the rest of it, we're wasting our time being academics, you should be in the real world. Well, Hannah, by surveying all the patient records and by understanding there's a real problem of treatment of people with learning difficulties, and they were much more vulnerable to virus, they were given vaccines earlier as a result of her research. So, we'd save lives as well, even if we're just doing systematic reviews. It's very valuable because hopefully people's lives will save because they're vaccinated. They had the vaccine before their age group. So she conducted this systematic review, and it's published this year in The Lancet Public Health, and she found that all-cause mortality was 2.24 times higher in people with disabilities than among people without disabilities. So modelling, they did modelling, lots of complicated public health, they break it up, epidemiology. Median gap in life expectancy of 13.8 years. So the median, that's no, I can't even tell you. What's the difference between mode, median, and mean? Median is it's the middle. So the middle, not mode is the most people. Median is the middle. So the mortality was higher. The median gap in life expectancy of 13.8 years. And the cause-specific mortality was also higher, including for cancer, COVID, cardiovascular disease, and even suicide. So all of them were higher, basically, all the common ones. So large gaps, and that's because of the health system. It's not because people have an underlying higher risk, it's because they're not, that's why I've said equity. So equality means that I give you all the same, right? Equity means that I go, well, you really like chocolate, you could have more of it, or whatever. Or you really need this intervention, you can have more of it. I'm not going to treat you as if you're all the same. And that's really important, because I think lots of folk with disabilities are not the same. They have health needs. Equity means making sure that those health needs are appropriately met, effectively met. And it's not just about the underlying impairment, it's about the health system. And this health systems approach, which we were very familiar with at WHO, is about policy, it's about workforce, it's about financing, it's about a whole range of technology, a whole range of things. It's the idea that rather than think we'll deal with this disease, or we'll deal with this disease, or we'll deal with this disease, it's actually about saying, no, we're going to solve health, we're going to solve the buildings, we're going to solve the workforce, we're going to solve the financing, or whatever it might be. So they showed that Hannah and her colleagues found large gaps in the performance of health systems. with respect to disability inclusion. So only 26, that's a quarter or so, of the national constitution's guaranteed right to health. Only 14 in Europe, this is in the EU, 14 of the 27 have legislation that prohibits disability discrimination and provides reasonable accommodation for people with disabilities in healthcare. And 5 made no provisions in either domain. So there's no equality either generally or in healthcare. So big problems. So me coming to talk once a year is, that's good. Lots of places have nothing. And it's not just about training. It's about cost. It's about transport. It's about buildings. It's about equipment. It's about information. And now I know that you're all confused when you go into the RVI or Guy's or wherever you go into, because they're busy and complicated places. But if the signage isn't adequate, and if it's not adequate for you because you find language difficult or your site is not very good, then you'll be excluded. You'll be more confused. And of course, attitudes and information. So what are we doing? I hope I've shown that there's all sorts of inequities. What are we doing? We are doing an RCT in Uganda, randomized control trial, a big trial of people who've had this training and people who've not. And so we want to train healthcare workers, and a healthcare worker is defined as any person who would offer a consultation or medical procedure in a clinic. So they could be nurses, counsellors, social workers, doctors, so anybody in a clinic is a health worker. And so people are trained, not just people with disability, but also who are trained to become trainers, but healthcare workers, so they're more aware. And there's a huge number of learning outcomes, but they're about disability inclusive examination, disability inclusive treatment, additional needs of people with disabilities, understand disability impairment within Africa, disability inclusive health, how to make appropriate referrals. So all of those things. So and the training goes on. It's good training, and the idea is that it will be available if it's successful. If the trial shows that people are better as a result at being healthcare workers. If people, disabled people find them better, then it'll be rolled out. And this is a manualized training, so it's available, it can be rolled out. It's quite straightforward. Now, I mean, it's quite interesting, how do you train people? How do you train healthcare workers? I think you can do that many hours training, but what was really important was training disabled people to do the training. Because I think it was important. They may not have remembered me, or they may have remembered me and they may not remember what I said, but they did change. I'm sure they changed. And I know that because people have written to me years later. So I've been doing this training since, my PhD, when 1989, I think I started my PhD. So I did the training in Cambridge also, and I get letters. I know you, Richard, and lots of people probably get letters from doctors about the training, but I still get letters from people who were trained, emails now, for people who were trained by me years ago. And at the time they may have laughed and thought it wasn't important, but later they did think it was important because they met ordinary people and they became ordinary doctors. And of course, as soon as you meet the general public, you realize all that social stuff, quite useful actually. As a doctor here, she's not here tonight, but she said 80% of medicine is making reassuring noises. So I'm sorry for all of the physiology and the science you taught people, but it's making reassuring noises, which is us, the sociologists and the communication specialists and the ethicists. So meeting disabled people is really good. And if you meet people, you do realize that you change your attitudes more than if you are merely taught by somebody who appears non-disabled, who doesn't identify as disabled. So, and one of the important things is having disabled doctors. And the reason that I went into medical education, the reason I did what I did throughout my career was because I think my dad was a doctor. and my dad was a GP for many, many years. And he was an early disabled GP. And I remember, because last week I met somebody who trained with him at St George's. And at that time, St George's was at Hyde Park Corner. They moved, now they're in Tooting. And they moved because there weren't any ordinary people at Hyde Park Corner. There were only posh people. And they wanted ordinary problems. They wanted people to have babies and all the rest of it. So they moved to Tooting. But it was really nice to hear the stories about training in the 1950s when my dad trained. But the answer, having disabled people being doctors is really important. And there's this massive case in India. So the Chief Justice of India, literally 2 weeks ago, delivered a landmark Supreme Court judgment and name-checked all sorts of people and so forth, because basically the system, the medical training system, had felt that disabled doctors were not as good as non-disabled doctors. And my dad was a good doctor, and this guy, Satendra, who took this case, is a good doctor. The fact that my dad was short, or this guy is in a wheelchair, makes no difference. He's still a good doctor. And they were instructed, the health training and the evaluation. The committee formulating the guidelines for admitting people with disability must include experts with disability or people who worked on disability justice. So they have a functionally competent test of medical aspirants with disability. So is it relevant? If it's not relevant, don't worry. Because it was quite interesting, because I trained doctors for 5 years officially as my job, and people would get in touch with me quietly. They didn't want to tell anybody they're disabled, because of course that would be problematic for their careers, but they wanted me to know. I learned about a lot of disability, which people were not talking about. So let me conclude, because I've talked far too much. So that guy is called Satendra Singh, and he is co-chair of the International Council for Disability Inclusion in Medical Education. So, and there was a woman at Northumbria who had my condition, who was short. Oh, she didn't actually have, if she really wanted to know, she had cartilage hair hyperplasia, which probably actually identifies her, because there are not very many people. Anyway, she had a restricted growth condition, and she wanted to be a transplant nurse. And every time, she had to have an assessment, a risk assessment, every time. Can you hold a baby? Well, of course I can hold a baby. But she had to demonstrate she could do all these things that were very obvious things, because they didn't want to really pass her. Anyway, she went through Northumbria. She got the job. She emailed me from Australia. She said it's much better here. It probably isn't. It is with better weather, but having disabled people as nurses or doctors or lots of different professions is very, very important. So I don't think disability is just a health issue, but this is one area. I could have come and talked to you, well, I couldn't, but you could have had somebody come and talk to you about education or about transport or about any area of life, employment, any area of life. But healthcare is important to everybody. It is really important for living our life free of conditions and a long life. And disabled people, 15% of the population, often are excluded from that. And every person with a disability probably has some sort of health condition, as well as the barriers that they face. And so you know about the Sustainable Development Goals, which replace the Millennium Development Goals, which are really important for the world to get better. And the Millennium Development Goals didn't mention disability at all. The Sustainable Development Goals do mention disability, so they are better. But the key SDG 3, ensuring healthy life and well-being for all ages. You can't get SDG 3 without including disabled people. So the missing billion, if you've not read their report and you're involved in healthcare, please download it. The missing billion, who are the missing billion? Well, unfortunately, often disabled people. So it's a human rights issue. It's a development issue. It's a really important issue. Aristotle, probably I was here when I learned that Aristotle, probably from somebody in this room, Aristotle said, treat like cases alike and unlike cases unalike. That's the definition of justice, I think, in the Nicomachean Ethics. I think it says, justice, treat like cases alike and unlike cases unalike. And I think that's what I'm talking about, really, justice. Because disabled people are human, essentially human, and they deserve the same standards of healthcare as everybody else, plus they sometimes have health conditions which should be treated or tracked with proper respect, with inclusion, with listening to the patient, all those other values that are really important. I will tell you, I wouldn't tell anybody else, but you're Georgie, so I'll tell you. The Lancet are going to launch a commission on inclusive health earlier next year. So, if the Lancet have had commissions on all sorts of things, but there's millions of pounds donated to this commission. So it really will gather the evidence and really will put inclusive health on the map. So not before time is what I say. So remember the Nicomachean Ethics. Remember, treat people alike or even treat people alike. People are treated alike. And thank you for listening.